David Wallace with PV Reporter, and we're reporting live today from ASH 2018, and we're sitting down for third or fourth year in a row with Dr. JJ Kiladjian from Paris, France. So it's a pleasure to have you.
Thank you. Hello, David.
Yes.
It's nice to be with you and discuss MPNs.
Yes, absolutely. Very good. So you had a number of studies, and there were so many that it was kind of hard for me to decide what I want to focus on, but I think we'll hit just a few of the highlights, and then maybe you can tell me some of the quick things that you had as far as perhaps new discoveries or takeaways here at ASH.
Okay.
All right. The first thing I wanted to talk about was the Ruxopeg multi-center phase 1 and 2 trial, and I wonder if you can tell us a little bit more about the background and the results and whatnot of that trial.
Yes, sure. So the idea of Ruxopeg came because we said that monotherapy with Ruxolitinib is helpful, gives a lot of improvement for patients with myelofibrosis, especially on the inflammatory part of the disease, but doesn't really affect the disease itself. On the other hand, we have interferon that gives nice molecular responses, histopathological responses, but sometimes is not well tolerated with a lot of, let's say, inflammatory side effects. So the idea to combine both drugs was maybe to hamper the inflammatory part of interferon with Ruxolitinib,
Right.
and maybe increase the rate of molecular response, the rate of histological response. Possibly this could be a problem because Ruxolitinib is a JAK2 but also a JAK1 inhibitor, or JAK1 is required for interferon efficacy. Interferon signaling goes through JAK1, so blocking JAK1 could possibly avoid the benefit of interferon. So this was the risk when we started the trial.
Okay. Actually didn't realize that, and as you may know, I'm actually on this particular therapy myself.
Oh.
And when I
combination?
Yes, I am. Now I have to tell you, when I first sat down with my doctor, Grunwald, it was our first meeting, and I literally sat down with him with the Danish study. And I was on 135 mcg a week on Pegasys, and I was like, it was killing me. I had all kinds of pains in my hands, my leg. And I just asked him, I said, I've read some really good studies, and Dr. Hasselbach is doing great research. And I said, will you let me try the combo and see what it does? And he said, yeah. He said, you know, as long as you don't mind coming in every week or two to get your blood checked and that sort of thing. So it's been a good combo therapy for me, and obviously the patient side is a little bit different than the scientist or medical side, but it seemed to me that the dosing levels, when you're looking at PEG at 135 a week and then 20 milligrams of Jacques twice a day, I mean, those are really high levels. Would that typically not drop most patients into a white blood cell low count or neutropenia or something?
So the Ruxopeg study was for patients with myelofibrosis, okay? And we decided the first part of the study that I presented at ASH this year, indeed was a dose finding. We had 3 doses, predefined doses of Rux, 10 BID, 15 and 20 milligrams BID, and the combo with PEG was 45, 90, or 135 micrograms per week. So 9 possible combinations.
Okay.
And we tested 3 by 3 with 3 patients in each combo.
Right.
And indeed, we looked for dose-limiting toxicities. Is something happening after 45 days of the combination or not? And we could go up to the highest doses.
Yeah.
So 18 patients were included in total. The 3 last patients received 20 milligram BID and 135 micrograms of PEG every week without any acute toxicity, let's say. So now the second part of the study, so we have 18 patients who started with very low dose but increased up to this one.
Yeah.
And now the second part will randomize to the two highest doses for 24 more patients. So at the end we will have 42 patients in the whole study.
Okay.
And hopefully see some, the first part was mainly to test the safety.
Right.
And the second part will focus on efficacy, but we already have some signals of efficacy that I will show during the ASH meeting.
Okay, okay. And you made a good point as far as it being related, the study-wise, to myelofibrosis. Because as we know, what may happen in MF may be different than PV,
Sure.
although sometimes it's nice when a medication does carry over. So, okay, so you're kind of moving into the next phase of recruiting and that
Yes.
sort of thing on that trial?
Yes, yes, because we already see some very nice efficacy results that were unexpected because most of these patients had very low doses of both drugs. But
Right.
besides that, we've seen, for example, very nice decrease in additional mutations. You know that in myelofibrosis it's quite frequent to have additional mutations on top of JAK2 or KRA mutation. And the patients enrolled in this study were quite high-risk patients. Many of them had A6L1 mutation, P53 mutation, EZH2 mutations that are bad, mutations. And we were really pleased to see that not only JAK2, but all these additional mutations also declined a lot on the combination of both drugs. And we also have a couple of biopsies performed at baseline and after 12 months of treatment, and I will show two examples of a clear improvement in bone marrow cellularity that comes back to normal, and even the patients where the fibrosis is gone after only 12 months. And to my knowledge, this is the first time that with a drug we achieve that. We can do that with transplantation in myelofibrosis, but with a medication, it's really very impressive. So we are quite excited to move forward for the second part of the study and to enroll more patients at these higher doses.
Okay, all right,
And
excellent.
I don't know your experience on the tolerance, but what you describe is what our patients are saying to us. Say we start with. It's a bit different than yours because we choose to start both drugs in patients who never received either drug. So it's not an addition of one to the other, but frontline we start with both drugs at the beginning. And we start with 2 weeks of Ruxolitinib, so the symptoms improve, patients feel better, and we start PEG interferon after that. And nobody complained of any adverse event, even up to 135, which in myelofibrosis is quite difficult usually to assess. So the clinical experience of patients is very good with this combination.
Okay, excellent. Well, we'll be looking forward to hearing more data from that research study, and you're presenting on that when?
On Monday. Monday morning.
Okay. I'm sure I have it on my schedule, but there's so many.